Yeah, I couldn't sort of stand the thought of just lecturing to you on prophylactic regimens and treatment regimens. So this is basically completely interactive with a few like studies, some evidence thrown in there. You guys know that opportunistic infections occur as HIV gets more advanced, as your CD4 drops and your viral load comes up. You guys have probably all seen this figure a million times of the natural history of HIV infection. The red line is your viral load, and the blue line is your CD4 count. So in the AIDS type of categories where you see opportunistic infections, overall, opportunistic infections have been declining in the US. This is slightly old, but you know, as ART became more effective and more widespread, we saw decreased amounts. I like this figure too, because it sort of gives you an idea of which opportunistic infections we see most commonly. So PJP, in whatever source you're looking at, is always the most common opportunistic infection. And then esophageal candidiasis, MAC, some sort of TB. And then towards the bottom, there's toxo, CMV, PML, meningitis, all, you know, less common, but we certainly see them all here at Tampa General. The one quick question on prophylaxis to get us started. Will, can you read it?
Which of the following infections with lifelong suppressive therapy indicated for a patient with a CD4 count of less than 50 and a high viral load, regardless of subsequent success of ART regimen in terms of CD4 count and viral load?
Here, crypto. What do other people say?
It's not E. It's not D. It's between A, B, and C. I'd go for B. I think crypto versus A. Yes.
Final answer?
Yeah.
A slash
there's a consensus.
A slash B. A slash
B.
Oh wow.
So we'll get to it. There's primary prophylaxis to prevent any occurrence of the disease. It's really only recommended, you know, PJP and tox are the big ones we think about these days, and we'll get to that. But there's secondary prophylaxis for more of the infections if they occur and have been diagnosed. And we'll go through some of the criteria for when we can stop those things. The questions are pulled some. This one I think is a board review question from the GW board review course. I also pulled some from like the HIV national curriculum, and then maybe from the purple book, and then some I just made up. So we'll start with a case in someone named John. You want to read?
Yeah. John is a 35-year-old man newly diagnosed with HIV, virus of 350,000, CD4 count of 10, and is seeing you to start ART today. In addition to starting ART today, what primary prophylaxis should be initiated? A, no prophylaxis initiated as of starting ART. TMP SMX 1 double strength daily. TMP SMX 1 single strength 3 times a week. Zithro weekly. Dapsone and Zithro weekly. Or
B.
yeah. B.
B.
Great. I was hoping that wouldn't be a tricky question for you. So we do this all the time, right? PJP prophylaxis when CD4 count is less than 200. The preferred regimens are Bactrim, either double or single strength 1 daily. And then the alternatives are listed there. I spelled it tovacone wrong, I see. But you can do Bactrim less frequently if someone has hyperkalemia or some sort of side effect. Dapsone and tovacone are alternatives. And then in the guidelines, options for Dapsone or Dapsone with pyrimethamine, and then leucovorin is to combat the hematologic side effects of pyrimethamine. Okay, John.
John,
It's not you.
I had.
John had difficulty obtaining his ART and prophylaxis from the pharmacy and was lost to care. 6 months later,
Poor John.
he presents to the hospital with over a month progressive breath, dry cough, and fever. X-ray, CT are shown, hypoxia 85 room air, crackles, satting around 60%.
What are you guys thinking this could be?
PJP.
What about it makes you think PJP?
Duration.
Duration.
Hypoxia. severe.
Yeah.
Yeah, there you go.
So yeah, diffuse infiltrates bilaterally on the chest X-ray and the CT as well. Yeah, just like that. But PJP can have a lot of different radiographic appearances. So okay.
Which test is most likely to confirm your diagnosis? Each body staining from the sputum, beta D glucan, or antibody staining from the bronch. Let's see. I think maybe straight from the bronch.
Bronch,
Yeah.
or even beta glucan.
There you go.
Yeah, so that's the most likely to be positive, right? A bronchoscopy sample is going to be a better sample, more sensitive than an induced sputum, which is far better than an expectorated sputum, which is pretty useless in the diagnosis of PJP, I would say. I don't know if I've ever seen a positive one from someone just giving us a sputum.
Oh, we had one time.
Did you?
We've had one.
Really? No.
Yeah, we've had one.
He was just teaming with it.
Mine are always negative and we just treat anyway. Okay, fine. Other people are luckier than I am. Yeah, that's true. Yeah.
I mean,
Yeah.
you actually have to have a really good respiratory
Tech.
therapy.
Right.
That can appropriately torture the people with the
Yeah.
high concentration of saline and make them cough it up and stuff like that.
Right.
So if you just tell someone to do it, it doesn't happen. But if you come from a place where they know how to do it, then they can feel it's actually pretty good and almost close to bronch. But
Yeah.
you have to have a respiratory therapy team that is willing to
Yeah, and I will say a lot of
patient into doing it properly.
a lot of times these participants, these patients are not as willing to be participants in that induced sputum process as well, I would say. Yeah, exactly. So and often you guys hit on the subacute nature. People sometimes don't realize how severe their disease has gotten because it's come over gradually and they've like limited their activity. And I think I see that a lot where they're like, well, I'm just a little short of breath. And I'm like, but can you get out of bed? And they're like, well, I go to the bathroom. And you're like, can you walk more than across your room? And you like realize they've limited their life because it's been coming on so slowly for them. But at some point, there's some tipping point where they realize something's really wrong. And usually your exam isn't super impressive. I mean, you may have some rails, crackles, but the hypoxia is often impressive. And we talked about the workup of chest X-ray and CT and which samples are the best. PCR comes up more and more often. I think people are using it, but I think the key point there is that PCR doesn't tell you if they're colonized versus cause of infection. I feel like this came up, this is a side note, but with our Carious testing, like, I remember when someone came and talked to us, they're like, oh, we're underdiagnosing PJP, but I sort of wonder, are we detecting colonization? So I think, we're going to be coming up against, you have to remember the host and who you're looking at and whether the picture fits. Right.
Tests that we don't need will help with the data collection. Is that if it's truly pathogenic,
Mhm.
there should be some threshold and it should sort of cluster out in probably some sort of biochemical thing where the likelihood, particularly with clinical symptoms, makes the
Right.
likelihood high. So
Right.
that means that the pretest probability has to be reasonable based on clinical
Yeah.
parameters for you to send the test. But this is the part that if you look in the fine print, they admit, but that's not.
Yeah, and I think in the board review, the lecture was like, if your PJP PCR is negative, it's a pretty good marker that you don't have PJP, like on a bronch sample. But if it's positive, that doesn't necessarily mean it's infection. You have to look at the host. LDH is, we all know that's non-specific. Of course, if it's super high, like 500, then it can point towards this, but it's never going to really give you the diagnosis. Beta D glucan, I know, is sometimes sent. This was a study looking at the beta D glucan levels in those with PJP and without PJP. So of course, the average is maybe higher with PJP, but I think on an individual basis, it's a little hard to draw conclusions from that.
Like clinical correlation and pretest probability, right? All of this is sums and points to the diagnosis, but don't make any decisions because your LDH is low or normal. Don't make any decisions because the beta D glucan was negative or not, right? Basically, you just have to kind of look at all of these markers as a whole and correlate clinically.
Doesn't it?
I mean,
It
if
has
it's
a pretty
high, I think
high.
you're worried.
Yeah, exactly.
Yeah, I mean, it has a pretty high negative predictive value in patients with
Exactly.
HIV/AIDS,
But
right?
they'll say, oh, it's
Almost
the LDH
90.
is normal, it's not.
I mean, some studies
You know what
up to 95% negative predictive. So if it is negative in an HIV patient, I mean, there's a very high likelihood that they don't have PJP,
PJP.
right?
But you remember that one patient that you had that had it, it was LDH like normal.
No, I had a patient, yeah, with an LDH that was in like 200 something.
Yeah.
But their fungitel was over 500.
Yeah.
And then they had the bronch and they had PJP.
Correct.
So the LDH and the beta D glucan.
Cancel each
have to
other out.
really, like line up.
Yeah.
But
Yeah.
The beta D glucan.
Usually high,
Okay, Becky.
higher.
You send the appropriate diagnostic evaluation. What do you recommend for treatment while you wait for the results? So he had PaO2 of 60, I think he's had 85% on air.
E. E.
Yeah. Guys all feel pretty. And in the case of severe PJP, there is a mortality benefit with early steroids, and we'll look at that curve in a second. So if you have mild to moderate PJP, which can happen, you can treat with Bactrim IV or PO. We always treat PJP for 21 days, regardless of severity. And then for moderate to severe, so in this patient who's hypoxic, IV Bactrim is recommended to start. Your alternatives are primaquine plus Clinda and pentamidine. Note that atovaquone is not an alternative for severe PJP. That came up on some questions I saw. And then adjunctive steroids. You guys got at the exact point. If your PaO2 is less than 70 or you have an AA gradient, then you need steroids. And these are the curves. The first one on that side is risk of respiratory failure in people who got steroids versus standard treatment. And then this is mortality in steroids or standard treatment. This is from 1990, this paper, so some of you probably weren't born then. It's old data, but it's sort of been the basis of using steroids in PJP. So we give it if they're hypoxic.
The other
Yeah.
thing is, old studies, and for those of us who are old enough to remember that first wave of HIV, I mean, all these, so contaminating is horrible and toxic, but it does probably work as well as Bactrim. Everything else works less well. So don't be afraid of using contaminating. The studies are pretty conclusive that all the other things, like from Clinda, they were used like on people who are walking around with HIV and, were low risk, and the failure rate was pretty high way back when. So, so what you can get, what you can do and all this kind of stuff, but don't be afraid to use pentamidine because, we used tons of it in the old days, and yes, it's horrible, it's toxic and stuff like that, but it probably.
It works.
No, but my point is that it works because I've seen people stay away from it because of the toxicity. You try to use probably or something else, and that combo just or atovaquone, and those just don't work as well.
So at Moffitt, there's a lot of PJP breakthrough cases when they're on pentamidine prophylaxis. We have a decent amount of those cases at Moffitt.
That's prophy.
But would you still, if they fail with pentamidine prophy and they for some reason we can't use Bactrim, would we still treat them with pentamidine?
They're only doing it like monthly.
I know they do them
Yeah.
IV. You still would? Okay.
Yeah, probably.
Okay, same question. If patient AIDS misses a few doses of Septra for about 3 weeks, would you give them
Right.
Septra?
Yeah.
Yes.
And it's pretty,
And it may not approach statistical significance, but daily Bactrim works better than 2 or 3 times. a
2 or
week.
3 times a week.
It
Right.
does.
It does that,
It's
yeah.
just, that is it worth doing it on a population level? Maybe not. But everybody who treats a lot of these things, you get more breakthroughs on intermittent dosing.
Yeah.
You just do.
Human
It
beings.
may not be worth it on a population level to do that. You just get more breakthroughs if you give these protein doses, like for Toxo or PJP. If you do a few times a week versus, in fact, it's also even with TB. If you treat with the intermittent schedule, you get more failures or breakthroughs. So it's titrating convenience, compliance, efficacy. But all of these regimens, if you give a lot frequently, they tend to work better. And there's enough data out there that we've done a lot.
Awesome.
But so probably we would use pentamidine, but it depends on the clinical scenario.
Yeah, and you always try to give Bactrim if someone has a sketchy, self-allergy history that you don't really believe is a true allergy. You try to get them. Okay.
For PJP by immunofluorescence. The college reports several inclusion bodies in the BAL. The critical care team calls you overnight to request the addition of IVA cyclovir. The best course of action is what?
This question came from board review with.
E.
Those are the most difficult ones.
Politely decline. That's the.
I might have added the politely.
That's the very. I would just say no.
I'm sure overnight you're very polite always.
Try to be.
Yeah, CMV just really doesn't cause pulmonary disease and HIV. You can detect it there, but it's not the main cause of disease generally. In this case, it's the PJP that's making
This
shots.
happened in like a hospital
You
transfer.
see a lot
I
of
had that
this,
they had already gotten treatment and
know.
like once again cyclovir. I was like, why?
Yeah, because when they do the bronch, they send just that like shotgun panel that they sort of send for everyone. So you end up finding these incidental things that aren't real issue, but you all, ID's following. We're going to get ID's opinion on Adgan cyclovir here.
3 o'clock in the morning. Yes.
Generally, yeah.
Generally, yeah.
The report might have come back at 2 in the afternoon. No one thought.
Stay in the PTH or we do like a GMS or, you know what I'm saying? Because
Yeah, I know. I don't remember which one.
I don't, yeah,
It's a GM stuff.
I feel like we do the
That's
GMS.
I think
That's
we do.
what- Yeah.
Yeah.
They're different.
This slide's too busy, but the most, I think just remembering that in people with HIV pulmonary disease, of course, we think of PJP, but like standard bacterial pneumonias are still quite common. They can be more severe in those who are immunocompromised, or like viral infections. There are some uncommon things, some of them opportunistic infections like Histoplasmosis, Toxo, KS, Kaposi, and sometimes that's detected on bronch when they go in and can see it. And rare, like CMV and MAC are things you may detect an HSV on a bronch, but that probably are not the main cause of disease going on. And always remember they can have non-infectious things or and then
He has continued empirically on IV trimethoprim sulfa and steroids on the second day of treatment. He develops a widespread rash with oral ulceration and eye involvement. His TMP-SMX is identified as the likely cause. What is the most treatment option? Either continue the Bactrim, start immediate desensitization, switch to Dapsone plus trimethoprim, switch to atovaquone, or switch to Clenda plus primaquine.
Tamidine is not given to you as an option.
E.
E.
Yeah, and so that's the, for moderate to severe PJP, we know Bactrim are strongly preferred, but in someone who's having a very severe reaction like this with mucosal involvement, you're not going to continue that. So your alternatives are pentamidine or primaquine and clindamycin. And I didn't make up that question, so I didn't choose the answer.
Yeah. So I have a question. Jackie, I just joined.
Hey.
This is great. Hi. So I know that is when you got asked on the board, but primaquine is not really available on formulary. I just want to see if our stewardship colleagues or any pharmacy on here, practically what are people doing right now I personally have not encountered these issues recently, but what you normally do.
Primaquin not being on formula. We were able to get it.
We are able to get it. You're able to get it. It's just, it's more expensive than minocycline. It's very expensive.
Yeah.
Really.
And then, yeah, and Dr. Kim had just talked about how pentamidine is actually probably the best next choice after Bactrim.
Mm-hmm.
So that would be the answer.
So
That's the real answer.
So
Yeah.
you can get it. It's just not fiscally responsibly obtained to.
How much is it, Jose, per dose?
I don't know. I
Okay.
don't know, but it's obscene. It's much more than you would think.
All right. Okay. Okay. I'm not gonna stir it anymore. Thank you.
Next question. John is getting better on treatment. Good job, John. When should John start ART? A, he should have started on day of admission, 2 weeks of starting PJP treatment, 4 to 6 weeks, or an outpatient follow-up with the health department. B. 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 He should have started on day of admission. Technically he can.
Crypto and
Crypto and TB are the only meningitis of the two. He should have started.
Well, within 2 weeks means you could have started anyway.
Yeah, so
Yeah,
B.
but-
Yeah.
The real answer is within 2 weeks. There are some, these papers are obviously older about when you start ART, and for most opportunistic infections, and we'll get into the exceptions you guys have mentioned, early ART improves outcomes generally, and early was always in 14 days. So they give you a little bit of time to figure out what your acute diagnosis is, whether it's one of those opportunistic infections where you maybe don't want to start ART immediately. And deferred in this trial was just any time after completing the treatment of opportunistic infection. So for PJP, that would be 3 weeks or more. So this is one of a few different studies that sort of had similar outcomes. So that's the standard recommendation, though, of course, we all know in practice, sometimes other things do come up. Okay, well,
John completes the course of treatment for PJP pneumonia and starts ART prior to discharge. He is started on dapsone prophylaxis.
Oh.
Days later, patient with headache, shortness of breath.
Why?
Chest is normal. Pulse ox shows oxygen saturation of 85% on room air. ABG shows a pH of 7.4, PO2 96, O2 sat 96%, methemoglobinemia 25%, which of the following is the most likely cause of the patient's syndrome.
Dapsone.
Dapsone.
yeah, and we had one of these at
Of course.
TGH pretty recently.
Oh.
Yep. So, and he actually had pretty significant hemoglobinemia, and we just watched him pretty much, but stopped the dapsone. So dapsone and primaquine are your hemoglobin.
Remember this one, because this one, like, probability of something like this being on the boards is extremely high.
Mhm.
This?
I think like every time I've taken the boards, it's been on it.
Really?
The board question.
For
I mean,
research and everything,
sure.
so like, I can't remember.
I am boards too.
Was
Yeah.
on it, but still, like, my original boards and my research. Like, I don't remember the last time, but like it's been on multiple times.
Yeah, and it is like an IM board question even. It's not necessarily ID specific, but obviously our drugs can cause this.
The steps and IM boards love G6PD questions.
They really do.
Yeah. They love it.
Yeah. So don't forget, this one was sort of obvious, but it also happens in real life. So
Yeah.
we saw that recently.
And you could still, right, have like normal like G6PD, but then still get that because that's two separate things.
It's weird.
Yeah.
You can.
But they both
It's not
cause
perfect.
either thing.
I don't think they're related. P6PD.
But both primaquine and
Right, to the
That's-
hemolytic anemia.
cause the hemoglobin.
Mhm.
Okay.
I know that was our prisoner guy. Yeah.
Oh, Maria.
Okay. Next up, we have Maria Pucha.
A 39-year-old woman from Brazil presents to the ER with a seizure. CT scan is shown. HIV positive, CD4 count of 20, viral count of 100,000. Due to CT had findings, LP is deemed unsafe.
Why?
Neurosurgery declines to perform brain biopsy and recommends empiric treatment. Serum toxo IgG is positive. What is the preferred treatment? Atovaquone, Clenda, and Primaquine, Bactrim, Doxy, sulfadiazine, and
See,
So what are you guys treating for?
Toxo.
E. Yeah.
Yep. So E, as you guys said, and we'll get to the empiric treatment in a second. So acute toxoencephalitis, this is from the National HIV Curriculum. These are the most common symptoms at diagnosis. You can see none of them are that great. Like 55% of patients have a headache, 52% have confusion, a little less than that fever, lethargy, and then seizure we think about as an on board questions often comes up with toxo, but it's actually 29%. So a lot of people do not have seizure, probably depending on how advanced it is when you. And ideally, you would love to get a definitive diagnosis with an LP that has a positive toxo PCR or a brain biopsy. But often in these cases, it comes up where no one, everyone thinks that's dangerous. So you treat presumptively for toxo.
And PCR is only positive, probably maybe up to 50%, maybe 30%. So having a negative PCR only means it's negative.
Right. And so what you base it on is sort of the things that you guys all weighed in that question. Your appropriate host. So you have someone with advanced HIV and a low CD4 count below 100, and probably not on Bactrim prophylaxis. Clinical manifestations, they have appropriate symptoms. They have a positive toxo antibody, though remember that how prevalent that toxo antibody is depends on the population. So in the US, about 20% of the population is seropositive, but in other parts of the world, it's as high as 80%. So that may be less helpful as a distinguishing factor. And then your brain imaging. So brain enhancing lesions, and often involving the basal ganglia, but you can have one big one, you can have more small ones. These are from board review course of different images of CNS toxo, how, the MRI tends to look more impressive than the CT, but it's there on the CT. The other imaging has multiple lesions, so it can have, different appearances.
So there's no way to distinguish CNS lymphoma, but stuff based on imaging.
Right. So, and we'll get to that in a couple of slides. Yeah.
Jumping in.
Yeah.
They present similar to this, even if they're not immunocompromised in any other way. Like,
You mean primary infection versus reactive? This is generally reactivation, the CNS infection. Yeah, I don't know if you had the race. Right.
So this is why it's a complete screening thing. Even pregnant women who get acute toxo, most will not be symptomatic or so asymptomatic, or have such itsy-bitsy type symptoms that so it has to be lab screening.
has to be what?
Screening, screening by serologists.
Okay.
I think you're like the fetus, maybe what you're more concerned about.
Yeah.
Right?
Yeah. You're more concerned about the fetus.
Right.
The mom will
Right.
will usually not have anything that is transmitted to the baby.
Your pharmacist tells you that they cannot obtain sulfadiazine and yeah. What do you start instead? Atovaquone, Clenda, Primaquine, Primox, Oxy, Azoxanide, EMP, SMX. I would start.
Whoops.
Okay.
Didn't intend to skip that far, but yeah. Yeah. And so your preferred is pyrimethamine sulfadiazine, but I think more and more people are finding that Bactrim is also quite effective in the treatment and often easier to obtain, especially for the long course of it, because people often are not in the hospital for the full 6+ weeks of treatment, and often it can be beyond that. And there are other alternatives as well, but really it's Bactrim that tends to be used. Also, a quick note on prevention. Remember that we always think about PJP prophylaxis as we did in our first question, but if CD4 is below 100 and the toxo IgG is positive, you also need to make sure they're on something that covers toxo. If you can do Bactrim, that's easy, it covers both, but if you can't, then you have to remember that Atovaquone alone, well, Tova plus minus can, but Dapsone alone would not cover toxo prophylaxis. So these are what the guidelines recommend. And then, okay, so like we talked about when we in this case where you have a clinical situation that looks like it could be toxo and you start empiric treatment, the next question gets at how long do you give it?
They may be B.
That's what I was gonna say.
B.
Okay, we got a lot of B's, and you guys are right. It is. So if you're starting this empirically without a confirmed diagnosis, because often people don't want to jump to brain biopsy if you don't have to for obvious reasons. So this is a graph that showed of people who responded to toxo CNS treatment. At what point in time did they show a clinical response? And so they marked day 14 here on this graph as like 90% of people like had an improvement. But if you go back even further to like probably around day 7, it's like half of people who are going to improve have improved. By day 10, it's even more. So most people probably won't wait 14 days, but maybe 7 to 10 days to see if for clinical improvement. So is that Celia?
Yeah. For 10 days of treatment, she is not improving. Brain biopsy is performed at this time. What is the most likely diagnosis?
It looks like a trip.
Yeah. You guys should listen. Yeah, so this is another board review question.
From Brazil.
So trypanosomiasis Chagas disease, T. krusei, it can cause a chagoma in your severely immunocompromised patients. Again, with a space occupying lesion, and she just had the one lesion. So the board review doesn't even get into how you would treat this because that's certainly not board review testable, but
That you can recognize it and,
yeah.
and that it does occur, although rarely it does occur.
So cool.
Yeah, and she was from, you guys might not remember, she was from Brazil in the initial question, and so she has the background, the FE risk factor for it. But yeah. And then this is less of a question. This was more just, I thought, fun images from ID board review about different imaging findings and sort of what they point you towards. So, and these are people with, this is less a space occupying lesion, it's more someone with dementia or neurocognitive deficits. So A is sort of showing general atrophy. B is showing mostly white matter changes. C is, you know, basically the patient we just looked at with toxo versus chagoma. And then D is showing periventricular changes. Anyone have thoughts on any of those?
Septic MLI for A. Ah.
So yeah, HIV dementia, I mean, you couldn't guess from that alone, but these are just hints that you look for. So like HIV dementia is just general atrophy and loss of mass. So the ventricles are enlarged. PML is white matter. It's asymmetric. It's sort of scattered. Could be all over the place. C could be different things, as you mentioned. It could be toxo, lymphoma, chagoma. It could be all of those things in our differential. And then, the periventricular findings is particular for CMV. I think I had a question on that on my boards. And that came up a couple times in board reviews. So try to remember that association.
So basically it just kind of lines up around.
Mm-hmm. Yeah.
Chronic 70-year-old brain.
Toxo and lymphoma are really hard to tell.
Yeah,
Aromatic
you couldn't.
and supposedly, honestly, you know, ring enhancing and stuff like that is the multiple is supposedly more toxo. Lymphomas less likely, you know, but honestly, you can't really know.
Right. Yeah.
I feel like D could look like a lymphoma too. You get a big white matter lesion.
Yeah, and with PML, you can have it in different parts. It's hard to tell on these tiny little images, but it's just sort of some of the associations to know.
And it doesn't look as an organ type, you know, like if you have a lymphoma, it's usually a little bit more discrete, whereas PML sort of like
Circumscribed.
It doesn't look as much like a map.
Yeah.
Right.
And going back to toxo, sometimes there's always a question of starting steroids because they're not sure if it is actually toxo. So there's usually no contraindication from our
They
standpoint.
haven't been used on steroids.
Yeah,
So
the big challenge
We had
is
that
that
question on our patient.
So the issue is, remember, we want to look at if we're doing this presumptively, we want to get an answer
Right.
weeks later that you have an imaging improvement. If you give a lot of steroids and it ends up being lymphoma, you're seeing an improvement because of the steroids. So you kind of weigh the risk of that and say, if there's edema, you got your hand.
right.
If there's a lot of edema, your hand's kind of tied. If you already had stroke-like symptoms or have seizures, your hands are already tied. But if you don't, then you can date how much steroids you give, because if you're relying on that 1 or 2 week endpoint to see if you improve, you got to make a decision at that point. Is it because of steroids or is it because of toxic treatment?
Right. Since it's a diagnostic trial too, it can muddy the water, the steroids. So, but like you said, sometimes you have to
You have to
do it and you're stuck with it. PML can look a lot like MS because of the patchiness. Yeah, CMV, it's just that periventricular word they love. I came up on the. I'm not saying any of these are perfect. You would be given more information. This just was the slides they showed at board review to think about.
But thinking of an HIV positive patient.
Yeah.
So this is.
Yeah.
No, right.
Yeah.
I think you're absolutely right. But this is where the clinical context makes a huge amount of difference.
No, it's true.
Okay. Who's next for our headache patient? Okay.
George is a 28-year-old man with HIV, not on ART. Most recent CD4 count was 18, viral load 500,000. He presents to the ED for a severe headache and fever for about 2 weeks. He denies neck stiffness. On exam, you notice a few small umbilicated papules scattered on arms and legs, similar to the image shown. Which the following will be most helpful in obtaining a diagnosis, either blood culture, CT head, MRI brain, or LP.
LP.
Are your blood culture is going to be positive?
Maybe, but
Yeah. Okay. You guys are pretty clearly LP. What are you going to do first? There's a lot of, I didn't actually put in slides about this, but data on how, when you really need a CT and how helpful is the CT. In someone with advanced HIV, everyone's going to get a CT head, but we probably overdo it before lumbar puncture in general population. So you guys were right, lumbar puncture. So just to remember with cryptomeningitis, nearly everyone has a fever. Most people have a headache, but some of those things we look for, like a stiff neck or like photophobia, are actually a lot less common. And it sort of, it probably depends a lot on how advanced the disease is and how early you catch it versus late. So you don't have to have stiff neck plus fever plus headache. Like you can just have a couple of those, and in the right patient like this, especially with his skin lesion, sort of gives it away, but you'd be concerned. And just a quick reminder of headache and HIV. The blue ones are different, some opportunistic infections that can cause it are more common ones. Crypto, PML, toxo, primary lymphoma. But remember, it's not all opportunistic infections. There could be other infections, neurosyphilis you always want to evaluate for. And then if it's a mild headache without fever, dolutegravir is sort of known for causing a headache, especially when people first start it. Not always, but okay.
what is the most sensitive test for diagnosing HIV-associated cryptococcal meningitis? Serum cryptococcal antigen test, serum PCR for cryptococcus, CSF cryptoantigen test, CSF PCR for cryptococcus. The CSF PCR? C or D? Yeah.
Or crypto and
C or D?
Okay, C or D is what you guys are saying.
Yeah, C.
D. So C is actually generally better than PCR for board review. And so cryptoantigen, highly sensitive, and it's often positive in the serum too, but it's not always with cryptomeningitis, I have to say, in here, but mostly will be. Your CSF profile, usually a somewhat mild lymphocyte pleocytosis. The big thing is the opening pressure you're always looking for. It's mostly elevated, though not always. PCR can have false positive, false negative. It's usually you wouldn't order that, but it occurs in your like CNS panel that you get is cryptos on there. And we've had it before where that's negative, but the antigen is positive from the CSF. So definitely want to make sure you're sending both if you're concerned. And then according to everything I read, blood cultures are positive. Some say 50%, some say 60 to 80%. I don't know that I've had it quite that high in my experience, but it can be. Right. I thought those numbers were higher than what I had seen, but usually you're not relying on blood culture to make this diagnosis anyway. So that's usually more of like a, oh, look, let's turn positive. Okay. Yeah.
Like for, we had a patient recently on our team that they were post zone effect with the
Prozone?
post zone.
Okay.
Post zone effect where it's like if the antigen is too concentrated that the test will end up being negative. You have to dilute the sample to get the positive.
It's like prozone, but it's with antigen. Prozone
Yeah.
is with antigen. Yeah.
Yeah.
But I mean, you have to ask the lab specifically for that. Like, when should you suspect that if like getting a negative test? And this specific patient has negative LP, but the serum is 1 to 40 titer. You don't know why.
Well, did you also say, I mean, also if you send a CSF culture, like I think I had it once where it's negative and then the culture grew it. So that was sort of gave us our answer there.
Yeah, the culture's
He kind of had like vague superphobia.
Yeah.
But he had like a bunch of stuff on.
It usually occurs with a higher, I would almost expect a higher titer. I mean, I know it's serum versus CSF, but that doesn't seem quite the right situation. I don't know the exact answer and I never heard of post zone. Fun fact.
Yeah, no, there is a prozone and a post, but it's
Okay.
not the test.
It's like one's antibody, one's antigen.
Yeah.
Over.
An LP is performed after 30, plasma pressure 20, WBC 22, 80% of the sites, CSF buccal antigen positive, CSF culture positive, buccal neoformans. What is the preferred treatment for buccal meningitis? Ephoterasin and flu site.
Steroids or no?
D.
Okay, yeah, most of you are saying no. This is correct. This is the preferred treatment regimen. We're going to get to treatment regimens in just another second, but one quick question on flucytosine. Yeah, see with flucytosine, we're watching the cell counts. Which one gives you prolonged QTC? Which fluconazole, yeah. And then you all know about renal dysfunction and antiretroviral. So cryptomeningitis treatment, these are the recommendations. You do induction therapy. Your preferred is liposomal amphotericin B and flucytosine. Alternatives include fluconazole plus liposomal amphotericin, and you can see the other combinations there. Often a key part of induction therapy is if the intracranial pressure is really high, you may need up to daily LPs and potentially a shunt. Can often be very hard to get daily LPs in my experience. So even if you think the person really needs them. Yeah, that
never do them.
right.
The guy like that.
So there are some things in this talk that are what the guidelines say. So I'm trying to make sure you guys see what the guidelines say, and then clinical practice is different. And you give, generally about 2 weeks of induction therapy, and then we'll talk later about the exact criteria to switch to consolidation, which is a high dose of fluke. And then you do that for at least 8 weeks, and you switch to maintenance for a long time. And we'll come back to that. So yeah. So cryptomeningitis has like so many New England Journal randomized control trials
Right.
For ID. I feel like it's one of the most.
I was gonna ask about this trial. Yeah.
So yeah, some of us, if we found, had talked about these, but you can see the big one is like all-cause mortality, and this bottom one with like 5 different treatment options. And the purple line, the lowest mortality, is the ampho plus flucytosine for 1 week. They tried 1 week versus 2 week combos too. Ampho plus fluke is like the highest mortality, not that those are all significant differences, but this again shows like ampho plus flucytosine lower mortality than ampho plus fluke. So this is our recommended regimen. Another comment about, steroids was one of the potential answer choices. This was a trial for adjunctive dexamethasone in HIV-associated cryptomeningitis. It was stopped early because survival was lower in people who got steroids as well. And you can see this was in Africa, I forget what year, but this is like terrible mortality rates overall. It's like a 50% survival rate at that 6-ish month mark. But steroids were worse. So we don't give steroids for the initial treatment of cryptococcal meningitis. More recently, a couple years ago, a trial came out. Sorry, I did not get a high quality image here, but single dose of liposomal amphotericin B for cryptomeningitis. The regimen is like the single dose plus 2 weeks of fluke and flucytosine versus a control, which in this case was amphodeoxycholate and flucytosine and then fluconazole. Was this in Africa?
Yeah.
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 Yes, hence the control regimen was that amphodeoxycholate. Like we always use Ambazone, the liposomal. So they said death was, similar, and there were fewer adverse effects in the single dose regimen. Has anyone ever given this? Dr. Montero, would you like to comment on this trial?
Why though?
I can afford this one.
Go for it. Yeah, so in the US, we have the resources. So this is more of a trial for like practicality in resource limited areas. We're giving IV therapy for 2 weeks that requires frequent monitoring is really challenging. And I would say in most of your people with severe cryptomeningitis, it's not like you're going to give them a dose of IV and send them off on their way. They're usually pretty sick. They have headaches. You're monitoring whether they need repeat LP. Like, it's not like you're going to save the hospital money by giving them a single, overall. You're keeping them in the hospital and monitoring them.
Might as well give them info.
Yeah, I think you need to know about this because it comes up sometimes and it is a recent trial, but it's not something that will probably change practice in the US.
It's dealing with the issue that no matter how hard you try to make it go away, AMPA works better. Like, AMPA works better, period, next,
right.
Move on. It's just that AMPA's toxic and these liposomal things are expensive, and giving it in an under-resourced setting is like, we don't have enough people with dollars or resources to make that happen. And so they're trying to get closer to what we would like to do.
Yeah.
So.
Yeah. Okay. Thank you. And John, are you next? Yeah.
Yeah, a repeat LP is performed as George nears 2 weeks of anti-therapy. He is feeling much better with headache nearly resolved. Pressure 20, white count 6, CSF crypto positive, CSF culture negative. What is the next best step in management? Continue current induction therapy until CSF crypto negative, continue induction, but switch to AMPO fluke. Consolidate therapy with fluke 200 daily, consolidate therapy with fluke 800 PO daily. 800, definitely consolidate. It's 800. Yes, I think it's.
I don't think the antigen is ever going to be negative.
Consolidation.
Okay. You guys got it. D, you're ready to switch to consolidation therapy at this point. This is the same figure we saw before for treatment, but the box says you can switch to consolidation when they're clinically better, of course. They've gone at least 2 weeks of treatment, and then your CSF culture is negative. Those are the official guidelines. You should not monitor serial cryptoantigens in general.
Please don't check them.
They get checked and you'll get consulted. Yeah.
Up or down, all over there.
Yep. Yeah, they're just not reliable, and there's no guidelines that, like, if you see it come down, that means they're getting better. If it goes up, they're worse. Like, it's just, we don't know what to do with it, so we don't send it.
Generally more is worse, but it doesn't correlate with therapeutic response. So.
Yeah.
When should you start ART? Immediately after at the diagnosis, within 2 weeks of starting crypto treatment, 4 to 6 weeks after crypto treatment, or after completing induction and consolidation.
C.
Okay, so this was another one of those crypto New England Journal randomized controlled trials of early ART, which is 1 to 2 weeks after diagnosis of crypto. So sort of in the realm that we do for most opportunistic infections versus deferred 5 to 6 weeks later. The top curve is overall survival. And so you can see that survival was higher in people who were deferred ART for 5 to 6 weeks. When they stratified it by what the CSF white cell count was, when you had more than 5 white cells in your CSF, there really wasn't much of a difference from early versus deferred. The difference was seen in those people who were severely immunocompromised, where their CSF white cell count was less than 5. Those people, those are the ones who, when they started ART and their immune system came roaring back, that caused problems for them. So they needed more of that crypto treatment up front.
I've had one crypto case where there was 0 cells in CSF.
X.
She was completely ignoring it. So you can see some of those cases. They're rare, but they're there.
And those are the ones you worry more about
Yeah.
when you do start ART.
That's scary.
The George starts ART 4 weeks after initiating meningitis treatment. He reports 100% adherence on this all. A month later, he develops headache again. CD4 has increased to 150. 3PLP shows elevated opening pressure with negative CSF cultures. What is the next best step in management?
So what's he experiencing? What is this clinical syndrome?
He's experiencing iris, some sort of
Okay.
iris.
Yeah.
Um,
Usually it would be in people not on fluke, but you guys agree with Lauren C?
yes.
Yeah, so you're generally going to try to continue that ART and fluke, and then you might have to reduce intracranial pressure if needed. Often it's not that bad, but a lot of times the iris is where you might use steroids in the setting of cryptomeningitis. I think in practice, I've seen this more often, less in people who've been treated for crypto. So it's possible, but in people where the crypto wasn't recognized and they started ART and then like had this mild headache that was just worsening after starting ART a month or 2 later. And some of those patients were on steroids for a long time because it was just really hard to taper them off.
Realistically, you just send patients to the ER.
So you probably would, because you probably want to make sure that you know what's going on. So first you have to rule out other diagnoses, make sure there's not something else causing that headache. Because I mean, if you're getting a repeat LP, we're not doing that at the clinic, right? So yes, you probably would be.
All resistant crypto, you ran into that.
Yeah.
It's possible. Yeah, in this case, his CSF culture was negative, so that's not it. Because you would
But I mean, you
think
would
you would
use
find
it
it.
with cytosine, right?
Yeah, he's
And-
now months out.
Yeah, no one's out. Then you transition to someone.
You don't see that a lot in crypto neoformans. Crypto gadii is the one where we've had cases of that's more resistant.
Yeah, that one case.
I think they're clinically resistant rather than microbiologically resistant, right? So they fail treatment, right? But I don't think that it's as much that they evolve resistance. It's just, because Dottie is just intrinsically more of a pain in the neck.
Yeah.
We've seen neoformans have been resistant too, because remember, a lot of these people coming in and out of the hospital having esophagitis,
Yeah,
the one, yeah.
I've come across lots of cases where I've actually had to use a different azole. And the only other azole that's actually even recommended for this would be Bori. Because the other ones don't get a skin of that.
Mhm.
Well, we had that one case and we had to put the guy on like 1,200 milligrams of Conazole because of the.
Yeah.
Or you go higher.
Right.
Yeah.
Yeah.
To that point, yeah.
Yep. Okay, so iris, you guys know about this. There's paradoxical where you worsen a known infection, like our guy who had cryptomeningitis, or there's unmasking where you find infections you didn't know about. The most common opportunistic infections where you have iris, though of course it can be anything, but MAC, crypto, TB, PML, CMV retinitis is one to think about. And then the management is generally you try to continue ART, you make sure you have the right diagnoses like you guys were getting at. You treat the infections you know about, and then NSAIDs and steroids are what's typically used to sort of manage symptoms and get people through. And And earlier we talked about this was the study, early ART improves outcomes. But our exceptions are TB, cryptomeningitis, and then if you have untreatable infections like PML, cryptosporidiosis, where you don't have great defined treatment, you really want to try to get those people on ART immediately.
If you have virus and you didn't know that something like crypto existed until they get iris, do you ever stop ART? You keep going?
Generally, you keep going and you just add on the steroids. Yeah. Okay, who's up?
Sheila is a 48-year-old woman with HIV, non-ART, CD4 65, viral loads 510,000. Presents to clinic to discuss ART initiation, reports rectal chest pain with swallowing, and altered taste sensation over the past 1 to 2 weeks. Exam, oral thrush is present. What's the next step in management? Start PO fluke for 14 to 21 days and ART. Admit directly for evaluation and IV mica. Start ART alone, follow up in 2 weeks. Start fluke alone, 7 to 10 days. Start ART, fluconazole, antiviral. A.
Good. You guys were confident there.
Yes.
Will?
You call Sheila a week later to check in. What will your next step be if she is not feeling any better?
A.
Okay. The point of this is that a dynaphagent HIV, especially if CD4 is less than 100, Candida is by far the most common cause. We do have other causes as we see there, like HSV, or as your CD4 declines more, CMV or aphthous ulcers. And of course, people can have a dynaphagia esophagitis for other reasons that aren't related to their HIV, as we see at the bottom. But the key point here is that, as the second bullet point gets to, you can treat presumptively for Candida if they're coming in with symptoms of a dynaphagia, and especially if you see oral thrush, so you don't have to. You can start with fluconazole and see how if they're getting better. But if they're not getting better, then you move on to EGD with biopsy. You're looking for other infections. You're looking for a fluconazole resistance. And you would, of course, do EGD if they have any like red flag, red alarm, whatever that word is, symptoms. ART timing, you can start ART at the time of diagnosis. If you have the patient in clinic, you're probably going to start them on ART then, rather than risk losing them if you send them out without it.
She was feeling better when you talked to her after 5 days of treatment. She's very grateful for her care and follow-up. She plans to complete the full course. She hopes to never experience these symptoms again, and asks how she can prevent infection. Secondary prophylaxis. Many secondary prophylaxis options.
Yeah. So, we talked about there's some things like cryptomeningitis where you're going to be continuing fluke for a long time. And someone who has esophageal candidiasis, you are not generally doing chronic suppressive therapy. Usually acute therapy is effective. The mortality from this is quite low. And, with suppressive therapy, you can increase resistance for this, for crypto, for other infections. And really, probably the most important thing is if you can get them ART and improve their CD4 counts, those people will not be having recurrent episodes in that situation. Are we okay on time for a little more, or we can stop? Oh, okay, yeah, we can stop at any point.
Marco, 45-year-old male, had 2 weeks of abdominal pain, cramping, large volume of water, ongoing diarrhea, presented HIV positive, CD4 were consulted for eval. 5 AFP stool, and 4 to 6 micro in diameter.
Yeah, sorry.
GI, sorry. Which of the following will be the most helpful in improving symptoms? Arrow, detox, Metro, or starting the time to start ART is yesterday.
C.
Okay, not confident. We're moving on. So cryptosporidiosis, CD4 under 100. The most important is just starting ART. Otherwise, it's really hard to clear this. We have someone at TGH who comes in rather frequently. Yes, I know Dr. Montero knows him well, so I thought of you as I wrote this question. sometimes you will give nitazoxanide or promamycin. They can be given in severe disease, but most of the time it's really just figuring out how to get them to take ART. It's often from contaminated water supply. Even if there's chlorine in swimming pools, this can happen. And men who have sex with men are at higher risk. All right, it's got small, but sometimes you think of different potential hints related to it. Obviously, CD4 count plays into what can be the cause. CD4 less than 50, you worry about max CMV colitis. If it's bloody diarrhea, you think about some of your typical causes of bloody diarrhea and even non-immunocompromised and CMV. If they also have fever and weight loss, then you think about disseminated MAC. Sexual practices, men who have sex with men are at higher risk for STIs as well as Giardia and other bacterial infections. And then the rest of them, antibiotics, homeless, non-infectious, sort of relate to everyone. So you guys would probably pick up on those clues. What was that?
Yeah, the published shows here he ordered Max 102.5, GI panel on. So what is the next step?
Stool AFB.
This is maybe not a perfect question, but you guys are getting the point, right? That you aren't attributing all of this to his cryptosporidiosis, right? What are you worried about?
So
Yeah, and remember that people with HIV can have multiple infections at one time. So if it doesn't explain everything, you probably have to keep looking. So that's what you guys are looking for, MAC. AFB blood cultures are the best test for disseminated MAC to confirm the diagnosis. That you can find it on stool AFB cultures, but they're not necessarily diagnostic of disseminated infection. You can have it even without.
Meds, you need to get both because you get a positive AFB in your stool.
I know you probably get both, but
Your AFB blood culture will come back for weeks.
I could have phrased it better. But yes,
Right? Positive crypto, but does that present with lymphadenopathy, persistent chronic diarrhea, right? So.
so you guys got the point, even if my question was poor. And you guys know that MAC and disseminated MAC, the risk is higher the lower your CD4 count gets. And really, when it gets down to those low numbers, the blue line is 6-month incidence MAC and the tan line is 12-month incidence. So when people have less than 10 CD4 cells, like a third of them are going to develop disseminated MAC in the next 6 to 12 months, basically. And that number gets a lot smaller once your CD4 count gets above 50 to 60 to 100. It sure feels common. I don't know that. Yeah.
Because you would think so, but I don't know.
I don't know, it's common.
It's really common, yeah. And the most common clinical manifestations, I sort of laughed at fatigue in 2/3. I mean, I don't think you're going to hear someone with fatigue and be like, you have disseminated MAC. But none of them, as you can see, none of the symptoms are like all that, high chance. Like less than half of people have the rest of the symptoms. So it's always putting together that whole picture, and often like that lymphadenopathy on CT or maybe cytopenias, those sorts of things you take as clues and put it together.
It's like TB with diarrhea and abdominal pain. Okay, that's basically what you have. If TB can be not specific as well, that's the problem.
Great.
Well, and TB can present exactly the same. Yeah, exactly. That's what we used to see it all the time. Like,
Right.
They have AFB positive blood.
Our overall prevalence is fortunately much lower of TB these days than MAC, but certainly worth keeping in mind. Okay.
AFB blood cultures are positive on day 14. MAI is detected, but you had such high clinical suspicion that you already had initiated MAC and failure in the course. What is the recommended preferred treatment for disseminated MAC and HIV? Azithromycin and butol, or Rifabutin and butol, azithromycin or Rifabutin, or amikacin, azithromycin.
What you guys usually give them?
RAE.
Yeah, so often, the RA, you give 3 drugs, right? This is just to make sure you know what the guidelines actually say. So this is the guidelines. The preferred therapy is at least 2 drugs. Chlorothrol versus ethambutol, but generally azithro and ethambutol are the 2 drugs you need to use. And then you can consider adding a 3rd drug in the following situations, which I mean, most people that you're treating for disseminated MAC are going to have a CD4 less than 50. So generally we aim for 3 drug regimens when we can. And often with the one added, it's susceptible. Okay, but this is preferred therapy is at least a 2 drug regimen. So
And does this relate to like the drug interactions between the RIPs and the ART?
So the problem you have is fluoroquinol is actually an option there, but they're generally resistant.
yeah,
They're generally resistant. So I have an issue. I sometimes give them, this is something I learned from Dr. Way. I usually give them medication while they're in the hospital, but I usually don't when they leave.
some of our patients still end up on that at some point, at least initially, as you said.
But I just have a hard time with the fluoroquinol being in there, even though it's in the recommendations.
Yeah, I agree. I don't know that I've ever jumped to that unless for some reason it's your only option. Who's up?
Per the guidelines, when should Chris start ART? Prior to initiating MAC treatment, at the same time as MAC treatment, 2 weeks after starting MAC treatment, or 6 weeks after starting MAC treatment.
E,
Same time. B,
start at the same time.
B.
Because technically it's not absolute contraindication.
So yeah, the guidelines say to start it at the same time. I think, well, I guess I changed it to 3 weeks. Another answer because I thought 2 was too tricky. But yeah, but most of us probably don't start exactly the same time because then you're starting like a lot of medications at once. When people have side effects, intolerances, it gets trickier to tease out. I think most of us, they're going to be in the hospital for a bit anyway, usually when they're sick enough to have this. So most of us would make sure they get on MAC and are on that and then start the ART. You certainly can get MAC IRS with ART, but generally the long-term prognosis is favorable and NSAIDs can be helpful. And just in terms of what you expect, when you start someone on MAC treatment, they often remain febrile for a bit. And you don't expect the fevers to improve for 2 to 4 weeks. So this often causes issues, like additional workup. But if they generally are like looking okay and feeling better and they don't have new symptoms, usually you just sort of let it ride.
Yeah, I've sent so many people home febrile still.
Yes. Yeah.
And I said, I know, it's gonna happen. Then go home.
Right. Yeah. So just be aware of that.
Chris's follow-up a year later, follows up a year later and reports excellent adherence to ART and MAC treatment. He's feeling great today without fever and night sweats and cardiomyopathy. He's hoping to decrease spill burden and asks how long he needs to be on MAC treatment. CD4 is 170, viral load not detected. 6 months ago is 120. What do you recommend? Stop MAC treatment today, continue MAC until it's complete 18 months of therapy, continue MAC treatment on CD4 counts at 200, or for 12 months, other CD4 is greater than 200. Ooh. You can stop it.
What CD4 do you need?
But I think it's
Yeah, I think you need a CD4.
not 200.
I will say for board review, I try not to do too many of these because board review said they weren't sure if these would be considered like more lookup questions than necessarily have to memorizing the indications for stopping secondary prophylaxis at all. But it's just important to realize that you probably will have to look it up sometimes. So he meets criteria to stop. Chronic maintenance therapy for MAC is the same as initial therapy. So you do that initial regimen the whole time until they hit 12 months of therapy, no signs or symptoms of the disease, and CD4 is above 100 for 6+ months. With ART, of course. But again, the board mostly considers those lookup, and we look it up in clinic, I would say, when this comes up too.
Like
No, like it wouldn't be considered a board question. They probably won't ask you this specifically because they think of it more as something it would be reasonable to expect you to look up, not no. Yeah.
CD4 count. So you're sitting here going, because for many of these, the risk is really like at 50 or below 100. But then the guidelines, depending on the OI, will say 200. And so you're sitting there like totally confused.
Yeah. Yeah. Agreed. And like this comes up for PJP if their CD4 count just never gets to 200 and they've been on PJP prophylaxis for like ever, but they've been reliably non-detectable and their CD4 is just like 175 and that's where they're living. Many of us after, it's been stable and they're non-detectable, the risk of PJP is very low in that setting. So you probably can stop prophylaxis. Okay, well, the other things I've left was a histo case and a coxy case, but I'm going to just sort of get to the punchline since we're about out of time. So this is another case of someone not in care who presents with hypotension, fever, cough, dyspnea from Indiana. And so he has disseminated histo. And the appropriate treatment for disseminated histo is amphotericin B. This is your map of your endemic areas. So don't forget that. But of course, it can occur outside of that range too, I would say. And in terms of making a diagnosis of disseminated histo, this is the sensitivity of each test. Antigen detected is the most sensitive from urine or blood. It can cross-react with other fungal infections. Cultures next, then serology and fungal stain is least sensitive. I'm not going to go over the details of all this, but generally it's liposomal amphotericin B for severe disease and then transition to itraconazole at some point per the guidelines. And there are criteria you can look up for when to stop suppressive therapy. And primary prophylaxis is, for the guidelines, is not generally indicated, but in highly endemic areas with low CD4 counts, you could consider it. It seems to reduce the incidence of histo, but doesn't have a mortality impact. So it's not like a formal, strong recommendation. And then this one is a case of a woman from Arizona, not on ART, who has skin lesions, fever, cough, dyspnea, lymphadenopathy, and is diagnosed with pulmonary coxy and disseminated disease without meningitis. And which of the following is recommended for disseminated coxy without meningitis? Actually, mix this up. Easy. We're going to skip to this. So that's the range for coxy. Diagnosis, the same sort of test as for histo. Sorry, I went the wrong way. And prophylaxis can be considered in endemic areas if you have a certain CD4 count and if you have a positive IgG or newly positive IgM. And so coxy is either an azole or if it's severe infection, amphotericin. If it's meningeal infection, it's fluconazole. And then discontinuing, this gets back to our first question about the lifelong treatment. So the final bullet point is for coxy meningitis, if you stop fluconazole, relapse rates are like 80%. So you can be fatal. So you continue suppressive therapy lifelong is generally the recommendation. Coxy, I know we don't see a lot of it here in Florida, but it can tend to relapse pretty frequently.
So would you treat meningitis with amphotericin initially, or?
The recommendation is fluconazole. When I was looking this up last night, it told me that amphotericin hasn't been studied for coccidioides meningitis. And if we had a case, we'd probably look at this data in more detail.
Sure.
But that is what the guidelines say, and that's their explanation for it.
Gotcha.
Yeah. It doesn't make sense to me either. And so that's why I was sort of trying to skip over it because I tried to look it up and was like, I'm not convinced. But that is the answer.
I know it works.
Right, exactly. I don't think, yeah.
Did you have the history?
Yeah, I'm done.
You go to the histo slide?
Yeah, that's all. It's the same, like antigen, serology, histofungal cultures. There is, I think.
Usually
Serology, you definitely can. I don't. What about the histo?
So the treatment, prevention, when to stop.
fixation.
DC, long-term, at least 1 year of azole, negative fungal blood. Okay.
Yeah. Okay.
Makes
Thank
sense.
you all for participating.